Hi, this is Janine Steen, speech-language pathologist and myofunctional therapist, and I am your host of the WHY-O-MYO Podcast. I hope that during our podcast today and the subsequent ones to follow, that I am able to answer many of the questions and concerns that are often brought up to me during evaluations or while I'm training both dental, medical, and speech-language pathologists. I also hope to dispel some of the myths and provide some insight as to who can be trained in myofunctional therapy, when myofunctional therapy is appropriate, how to identify if it is appropriate, and where can I go to be trained. So I want to start by saying I've been a speech-language pathologist for over 20 years and a myofunctional therapist close to 20 years. And during my time in the field, I have definitely seen and watched so many of our patients, but so much of the therapy evolve over time. Like anything else, as we become more and more aware and we see more and more cases and more similarities amongst those cases, our research is able to guide and gear our therapy approaches in order to make the program the most successful and also to make the program successful for your patients. One of the things that I did not realize as I was going through my initial training is that when you are a myofunctional therapist, it does not mean that you are all doing the same thing. For example, if a patient is receiving prompt therapy and you go for prompt training, the way that you prompt a sound is going to be exactly the same as someone that prompts that same sound 3 states away or 3 countries away. This is not the case for myofunctional therapy. I have often found that many individuals claim to be myofunctional therapists or trained in myofunctional therapy. However, they have not gone through an intensive training process. They have not been able to see the pros and cons of each of the approaches, nor do they ever get to see the long-term successes. Over the years when I began, or I should say many years ago when I began, it all started because I had no idea what myofunctional therapy was and why would we even refer for it. I started my career early on in the public schools, and my first day in the public schools during my orientation, I was told we do not treat patients that would need myofunctional therapy. This is considered a medical problem, not one that's academic. Oftentimes parents will come in to me and say, I tried to get my child's speech in school, but they tell me their issues are not adversely impacting their academic performance. There is the buzzword that we often hear. And the reason that myofunctional therapy is often not covered in the schools is one, because not every therapist is trained to not only identify or treat it, but because the foundation of that program or the foundation of a myofunctional therapy program is focusing on the muscles, the agility, the strength, and the overall motor plan associated with swallowing. When I explain that to parents, they look a little more puzzled than I did, I think, when they first brought it up to me and first told me about it. And it wasn't until I was able to get into the field, have a mentor, take multiple courses, and ultimately see patients for the last 20 years that I've been able to modify and change the program so that it would be more specific to therapists, or I should say more specific to speech-language pathologists and not the population at large. During the time that I was initially being trained, I was being trained in an approach that was devised by Daniel Garliner. During that time, as I spoke to other colleagues and friends that perhaps had no idea, just like myself, what myofunctional therapy was, they all directed me to an article or a research study that was put out by the American Speech and Hearing Association that spoke about the inefficiencies of myofunctional therapy and the lack of support that it was having by our American Speech and Hearing Association or our field at large. It is important for everyone to know that that statement and that paper has been retracted. In the past 20 plus years, there is not a lot of research on myofunctional therapy coming out of the United States. However, if you are in Brazil, they are on the cutting edge of myofunctional therapy. I do believe that many people, medical professionals, therapists, parents, when they hear the term medical myofunctional therapy, I think they believe more that it is a holistic approach, a little hoity-toity, how do I get this to work? Maybe it's going to cost me money. I think it's a fad type of approach to therapy. However, myofunctional therapy has been around close to 50 years. Even though the programs have evolved over time, myofunctional therapy as a rule and as a goal has been, or I should say as a rule and as a treatment approach, has been around since the very beginning, or I should say 50 years ago, maybe the beginning of me. So anyway, the other thing that was really interesting to me as I was learning and growing and being mentored in this field is that many times all the trainings are conducted, and the trainings for becoming a myofunctional therapist are conducted by dental hygienists. So that was definitely very perplexing to me when I first heard that, only because I wondered how a dental hygienist would be able to evaluate and treat articulation disorders, evaluate and treat sensory, chewing, swallowing, feeding issues, and also how that tongue thrust and their jaw instability is affecting all of those areas. Of course, that was one of my first questions, and the answer was, typically a patient will come for myofunctional therapy and then will also go see a speech pathologist to address all of those goals. That could definitely be time-consuming and expensive, especially because dental hygienists are unable to participate with health insurance, where speech pathologists are. It has definitely, over the years, and learning and participating in different programs and different approaches to myofunctional therapy, that I've been able to take these programs, the best parts of each, as well as the additional training that I have received as a speech pathologist, and create a myofunctional therapy program or training that is specific to speech-language pathologists. In the future, we are hoping that we could provide additional webinars regarding this information, but at this point, the only individuals that can be trained in myofunctional therapy for speech-language pathologists specifically are those that come and work for our company. So, as the education for myofunctional therapy has grown, as well as the overall education of dental, medical, and school-based professionals have increased their awareness, early intervention and the referrals for not just myofunctional therapy, but for all different types of disorders and concerns has definitely grown. I think the mindset that it's important to intervene early and try to change and create long-term benefits and effects, that is absolutely the same goal we have when it comes to myofunctional therapy. Anyway, as I keep going, I wanted to take a pause and swallow for a second, but here I am again. So during the course of all of these trainings and all of these things I've been doing, and while I've been seeing patients, I've also been able to spend time speaking with other medical professionals and dental professionals about some of the concerns that they see within their clinical setting, as well as speech-language pathologists that have ultimately hit a wall with regards to success and carryover for their patients. This is typically when myofunctional therapy is the choice or the best referral and the best approach. So myofunctional therapy has definitely, I know that myofunctional therapy is not often covered in the academic setting, and I've also explained how not every myofunctional therapist is trained to do the program or to do therapy the exact same way, thus not realizing or understanding that the outcomes and the progress can be the same. But most of the time when a patient is being referred for myofunctional therapy, it is those patients in your medical dental practice that are presenting with symptoms without etiology. We can't find the cause of the problem. In addition, when, as a speech pathologist working with a patient, it is often those patients that are stimulable for sounds and can improve within the four walls of your office and perhaps a structured setting. However, the carryover into the world at large and their ability to generalize has definitely will be limited. And that's often where our frustration as a speech pathologist comes from. So, Many of the times, these individuals have seen professionals that are treating just the symptoms and not the cause. So when a patient is referred for myofunctional therapy, it is typically because they have a tongue thrust. And a tongue thrust is definitely not a bad word. We are all born with a tongue thrust. However, over time, it matures and develops. If that maturity and development doesn't happen, then it will have adverse effects on your speech or your articulation, your overall jaw and jaw stability, and perhaps can cause TMJ. That weakness in your oral cavity or any interruptions in your airway can cause sleep apnea. In addition, difficulties with chewing and jaw grating and lateralization of food within the mouth often creates a sensory or texture consistency aversion for individuals that have the tongue thrust because they are unable to manipulate and break down the food because of all the other areas that have not developed or have not grown over time. It is important that we not just treat the symptoms of the problem, but we treat the cause of the problem. I always tell parents and professionals that we're essentially turning back the hands of time, and we're starting at a point where that child perhaps went off key or off track at the point where they should have outgrown this tongue thrust and it didn't. And what I mean by that is that the myofunctional therapy program is a hierarchy, and it begins with skills that we learned 7-8 months of age, or not, sat in a classroom and learned, obviously, but skills that your body acquires and utilizes over time. And it begins as early as 7 to 8 months. And by the end of the program, we're working on everything from drinking out of a cup to straw drinking to making sure we're sleeping well at night, to making sure we're breathing through our nose with our lips closed, making sure our tongue is sitting in the right place when we're at rest and not speaking, as well as in the right place when we're speaking or swallowing. This is where our approach to treatment and our approach to therapy is way far behind some of the rest of the world. Myofunctional therapy is looked upon very strongly in Brazil, and actually a lot of our research and a lot of the information and the ways we've changed the program over the years is directly related to the research that is being done in Brazil and the outcomes of that research. In Brazil, with every dental professional, there is a myofunctional therapist. Whereas I have found over the years, and it's definitely getting better, but it's still an issue, people think of myofunctional therapy as a holistic, voodoo, witch type of therapy approach, and we're just trying to get you to buy into a fad. And actually, that could not be further from the truth. If you think of an orthopedic surgeon and you break your leg and you break that bone in your leg, how does that improve? Well, it may improve by the doctor putting a cast on. It may improve by having surgery. But in order to improve that function, once the cast comes off and the surgery is done, and to build them back up, they typically see a physical therapist. The physical therapist's job is to work on the muscles of the leg, while the orthopedic surgeon's job is to work on the bones of the leg. That is very similar to myofunctional therapy. Our dental and medical professionals are working on the dentition, the hard palate, the jaw, the overall bones in the face, where the myofunctional therapist is working specifically on the muscles. When I spoke earlier and said it is important to treat the foundation of the problem and not just the symptoms. And that holds true in everything from dentistry to speech language pathology to the medical profession as well. Some of the examples I can say regarding this is that a patient that is going to be successful with myofunctional therapy cannot be a persistent thumb sucker or a persistent finger sucker. Anything that perpetuates a tongue thrust beyond the age that it should begin to become outgrown or has been outgrown is considered a detriment, but will also adversely impact the overall motor plan, the overall development of strength and agility, and in the long term could eventually cause articulation or orthodontic issues. I have definitely learned through my experiences with medical and dental professionals as well as therapists that most of them have not had a rigorous or coursework or a rigorous understanding of myofunctional therapy. And not only that, but how a tongue thrust can negatively impact the overall form of the oral cavity, form of the lips, overall posture, the shape of the mouth. And that's actually a detriment. Again, if we were to think about how successful we are post-surgery when we break our leg, that success is not just because the orthopedic surgeon corrected the bone, but that success is also because a physical therapist helped not only to build the strength back in that leg, but also we need to learn how to walk. And walking is a motor plan. And the second you interrupt that motor plan, your body has to relearn it again to make sure that those pathways are clear. That is the same thing when it comes to swallowing as well as myofunctional therapy. We do swallow anywhere between 1 to 2 times per minute, and that is not included when that doesn't include when we're eating. So if you think about the muscle of your mouth being your tongue, which is as strong as your heart, by the way, if you think of the muscle as your tongue and your teeth as the bone, if the tongue is pushing on the teeth repetitively or resting on the teeth are eventually going to move because the pressure of the tongue is way too great. A lot of people often say, well, I'll just get braces or Invisalign or retainer. Unfortunately, your tongue is stronger than all of it. Most often, those individuals that do not know when to refer for myofunctional therapy prior to orthodontics, they often see the need for myofunctional therapy post-orthodontics. And the reason for that is that many times this patient or your patient will relapse or start to show some regression, especially once the braces come off or once they're not able to keep them on any longer, or they're non-compliant with wearing their rubber bands, their retainers, etc. So it then becomes our jobs as myofunctional therapists to step in and get that muscle off that bone and teach it a new way to swallow and teach it a new motor plan. So myofunctional therapy is definitely a ton of work if you think about that. We have to change what's happening in the mouth every 1 to 2 minutes, in addition to reteaching how to chew and swallow correctly. We have our work cut out for us. I'm hoping that this was a good overview of myofunctional therapy, and please stay tuned for weeks ahead where I will go more in depth into the who, what, when, where, and of course why myofunctional therapy is important and a benefit to our practice. Thank you.